And if you look carefully, you can see the ridges are horizontal, and they also have quite raised, serrated ridges to this, which adds to the security of your instrument, which allows the tissues to be safely held without slipping. These come in two shapes, the straight one and a curved one. As you can imagine, the curved one is particularly useful for hysterectomy, as the tip kind of curls away from your line of vision, so you can actually see what you're gripping. The straight one is particularly used for your parametria after you take the uterine pedicle for the paracervical tissue, the McFarlane ligaments, when you do a hysterectomy. This is a Spencerell's, named again after a surgeon who devised this. A very common instrument used as a hemostat. It's got, again, horizontal ridges which holds the tissues very precisely and securely in its jaws. Very useful for obtaining hemostasis when you want to pinch a bleeding vessel. It can also be used to grip edges of the peritoneum, for example, when you're using to lift it up to reflect the bladder flap at a hysterectomy, to cite a common example.
Because the grooves across are deliberately put running along the length of the instrument or across the instrument, because if they're put across the instrument, if they're horizontal, it stops the tissues moving longitudinally.
That's right, yes.
And if the grooves are longitudinal, it stops the tissues moving horizontally. So they are selected for this particular purpose. I think the other thing that we were always taught with these instruments actually relates to when you're taking them off, so that when you're trying to tie a ligature, the trainee is taught to release the clamp but not release it totally. It was ease and squeeze is what we were taught, which I think is it's possibly one of the things that would be expected. You might be expected to say in the MRCOG exam. And the principle of that is that if you're tying a uterine artery, for example, then you have your clamp robustly on. The poor surgeon wants to tie his ligature and not have the clamp sprung off and the pedicle vanish. So and yet he wants to be able to tie the ligature so that the pedicle gets compressed. So you need to have your assistant release it enough to allow you to tighten the ligature, but not release it so much that the pedicle actually comes out of the clamp. So I think that's something that would be useful, some useful form of words that the MRCOG candidate needs to practice before they get into the examination hall.
And also, I think, just to follow on to what Tom was saying, the assistant to be able to correctly release the clamp and open wide when it has to come out eventually, so that you use your fingers appropriately so that you can open the clamp widely. Now, hello? I need to call you back. I'm in the middle of something. Okay, all right, okay. So I think about the easing and squeezing. I think for me, I am not much of an ease and squeeze person, I'm afraid. But the principle is very valid, that particularly when you're with inexperienced assistants, that they don't spring and you lose the pedicle. So it is very true, and it is very important to control the release of the instrument so that you still have it in your...
I think what you're doing, in fact, is demonstrating exactly the way the old technique was taught, that you were taught that you, first of all, you squeezed so that you actually have control of the pedicle, and then you open the lock, and then you just open it, you'd open a little bit while still retaining pressure on the pedicle so it doesn't jump out. I mean, it's not so bad at an abdominal hysterectomy, but if you were doing it vaginally and the pedicle vanished, you could have a sweaty moment or two while you retrieved it.
Moving on, the next instrument is a coccus forceps, which is very similar to a Spencerville's, except that it's got a tooth, a very traumatic one at the end. Quite useful for holding tissue which you wanted held securely without slippage. For example, the edges of vaginal skin as you do a repair.